Welcome, everybody. Welcome as we're getting you through the lobby and coming in here. Welcome, welcome. Lovely to see all of the names popping up. And I'm sure it will continue. But we are recording, so you can watch it even if you joined a bit late. So let's get into it. Welcome to Education with Team. It's a series of educational webinars that we run. And I'm Anne-Lone Dalhoff. I'm the Marketing Director of Team Medical. And I will introduce us to our speaker very shortly. Firstly, in the spirit of Alliance, we would like to acknowledge the traditional owners, custodians of country throughout Australia and their connection to land, sea, and community. We pay our respect to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islanders people here today. And on the little map in our catalogue, you will see as well the 4 warehouses and offices we have and the local people there. A bit of housekeeping. So, as you would find out, your cameras and microphones are turned off as participants. They're muted. You can eat dinner, have a coffee, but lean in and join us. We will be recording, so you can watch it on demand as well. You'll get an email tomorrow with the link. Our speaker will have an informative presentation and do Q&A at the end. But what we would like you to do is actually write your questions in the chat as we go along, as the speaker is presenting. So right now, let's just test that you can find the chat box and put it in there. So open your chat box, everyone, and put in hello and where you're from. Let's do that to make sure it's working for you. And let's see the chats coming through here. And in the chat as well, I can see there's a hand up. If you have any questions on technical things, please put it in the chat, because our marketing team is sitting watching the chat and they'll help you out if you have any issues with sound or anything else. Amazing to see the chat. Thanks for all your highs coming through. Perth, Melbourne, Geelong, Brisbane, Ravenshoe Medical, Victoria. This is great. We've got the whole country covered here from west to east. Let's see if we can cover from north to south as well. So keep them coming. Keep them coming. Beautiful. So keep doing this so we know the chat is working for all of you. If you have any issues, technical or not, please put them in the chat. And as there's lots rolling through, if we missed it, don't hesitate to just put it in later and say, help, please. Then the marketing team will come and help you. When we get to the Q&A at the end, anything that we have not been able to answer as we went along, we will combine, make a summary, and then Hayley will be answering all of these great questions we have. And then in the last minutes of today, we have our lovely partners here, Danielle Wheelerhan from Hartman, who's helping us run this event tonight. And she will share an app that can help us identify the best wound care solutions. And as well, we will do a little survey from Team Medical. And we would really ask you to just stay on that minute and answer a few questions. It's really to help us make them better every time, and share your ideas of what you would like to have webinars on in 2023. That is the housekeeping done. In 4 minutes. That's good. We're on time, Hayley. How good is that? Let's get into it. So, together with our partners from Hartman, we are so pleased to bring to you tonight this webinar with Hayley Ryan, Director of Wound Rescue, President of Wounds Australia, Clinical Nurse Consultant in Wounds, and so many more titles and other things. So you'll have to go onto her website and look later. Today, Hayley is focusing on leg ulcers, breaking through these hard to heal wounds. And we could see from the nearly 1,000 registrations we had that this is something that matters for all of you. So thanks for spending your evening with us to learn more about this. We really appreciate it. Hayley is not only the director, she is, as I said, clinical nurse consultant, and she brings a wealth of industry knowledge. So We're very passionate about education, and that's why we and Danielle from Hartman have partnered with Hayley. So Hayley, take it away.
Thank you so much. And I'm going to start by saying a big thank you to Team Medical and Hartman for the invitation to be here. And a big thank you to everyone on the line tonight who's joining me. Clearly, you're interested in this topic. I've only got an hour to present to you all of the intricacies that come with this topic, but let's see how we go. So it is going to be a talk on breaking through hard to heal wounds. Of course, I have to have a disclaimer just to let you know that during the presentation, you will see wound photos. So please be aware that some of them are quite graphic. I will let you know that I have absolute permission to use those photos and also to tell the stories. They're real cases that I have from my patients over the time. So please be aware you will be seeing photos tonight. Some of the learning outcomes that I hope you get from tonight's very short talk is a little bit about the principles of wound management, how you actually define a hard to heal wound, and you'll start to see that shift from chronic wounds into hard to heal wounds. Understanding the differences between venous and arterial insufficiency, how you assess and diagnose, how do you prepare that wound bed for success, and most important, how do you manage infections? And what I hope to do at the end is bring it all together and make it a little bit practical and provide some case studies. Now, I know what it's like. You get online and it's easy to really get distracted. There might be an email popping through. So I do try to make it a little bit interactive. So get prepared to be writing a few things in the chat. So let's kick it off. I want to start with the burden of hard to heal wounds. What we know statistically is that it's a global issue. In fact, in Australia, around 450,000 people live with a wound at any one time. It costs around $3 billion to treat, and it's around 2% of the health expenditure. Anyone who's been to my talks before, I mention this over and over again because we really need to continue to lobby our government about the importance of this concern, which is wounds, and we need your help to do that. But I would be remiss if I didn't talk about the evidence, some things that you can actually jot down and grab a copy of so that you know the information. And I'm going to start with the Wounds Australia Standards for Wound Prevention and Management. We are looking at updating to the 4th edition, but if you haven't got your hands on it, please grab a copy. There's also the Diabetic Feet Australia document, an excellent resource. I am an author on one of the chapters here, but grab a copy. It's one of those hard to treat areas because people get a little confused with what is a diabetic wound in comparison sometimes to, say, a pressure injury. And then, of course, the Wounds Australia document on ulcers, another great document. Why am I presenting all these? Because if we don't stay current with evidence-based information, we get a little bit behind, and that's because wound management is changing so rapidly. So if you can, grab yourself a copy. But I want to start with the principles of wound management. In fact, if you don't hear anything else tonight, this is the key, because the principles is all about identify the cause of the wound. In other words, how did the person get it? So if they present to your GP or to your hospital or to your aged care home with a new wound, ask, how did you get it? It's so important. Of course, we focus on holistic health assessment. After you've done that, then you can look at the wound and assess it. You always want to adjust the care regime to meet the response. And we always talk about trialing the same type of product for at least 2 weeks. Give it a real crack. If it's certainly not healing, or if it is in fact deteriorating, look to alter it. What's the overall goal of care? Are we looking at a palliative wound? Are we going to treat conservatively? Or is our goal of care at this stage just to minimise the exudate so Mrs. Smith can keep going down and playing bowls? Think about the goal of care, and of course, I've mentioned infection control. But when it comes to wounds, I'm going to give you the magic formula. Get your pens and paper out. This is all you need to know to heal every single wound, I guarantee you now. If they are eating good amount of nutrition, good amount of water, and they have lots of oxygen coming in at a healthy rate, every wound will heal. But I think you would agree, our reality is a lot of our patients don't eat well all the time. They often don't like to drink water, particularly if they're in that older age group. And a lot of people have issues with oxygen, whether it's COPD, emphysema, asthma, bronchitis, the list goes on and on and on. So we have a challenge on our hands as clinicians to treat these wounds when we've already got things going against us. So what can we do as a very basic foundation? Well, it's about focusing on the skin. Now, we always talk about, now I work in ED as well on the weekends, and can I tell you now, people always come in with chest pain and we say, okay, that's the heart. They come in with respiratory issues. Okay, that's the lungs. But I never hear anybody say someone's got a wound and the organ affected is the skin. And if we can start thinking of the skin as the largest organ on our body and start protecting it with a real focus, we will get better at preventing wounds from breaking down. And the reason I say that is because the skin is such a magical organ that if we protect it, it will do the work for us. Now, when it comes to normal skin, it does sit between 4 to 6.5 on the pH scale, as you can see here. In other words, it sits slightly acidic, just in this range here. The optimal pH that we will always talk about is 5.5. And the reason is because that's what we know protects the acid mantle. And the acid mantle on the skin will actually provide the defense against microorganisms. So protect the skin by hydrating it, whether it is with oral fluids or appropriate creams such as emollients or barrier creams, and even thinking about how is the person washing themselves when they go home. So they should be using pH neutral and soap-free alternatives, and that will protect them from breaking down again. So let's get to what tonight is all about. What is a hard to heal wound? And I just want to say again that we are moving away from the word of chronic wounds, and we're now starting to realize that it's more about hard to heal wounds. And if you have a look at the definition, hard to heal wounds is one that fails to heal with standard therapy in an orderly and timely manner. This applies equally to both acute and chronic wounds, and is independent of the wound type or etiology. And that is why we're shifting, because we now realize that just as much as chronic wounds, when we start to see them stagnating and not healing, in fact, acute wounds can have the same issues if they become complex. So with that, what are some of the factors that lead to this? Well, you would have all seen the healing stages here, and in any area, it can actually cause it to stagnate. And we often know that a lot of wounds, chronic or hard to heal wounds, get stuck in this inflammatory phase. So who does it affect? Often the elderly, and that's why we talk a lot about the elderly and wounds. Those that have comorbidities, if you think about those that may have diabetes, other etiologies, do they have venous insufficiency? Do they have cardiac issues? And maybe it's resources that is a problem. Think about those that maybe work in the community sector. Very, very difficult to manage when they've got limited resources, because it's the patient who's deciding what resources to have. And think about, do you have the clinical competencies, or can we actually improve in the education? And you're all here tonight, which gives me great hope that we're working together. And then you start to factor in other elements that can actually delay wounds from healing. And we've known over the last few years, in particular, we're seeing over the last 8 years, especially, the notion of biofilms. And I'm sure you've all heard of biofilms. They're basically microorganisms that get really deep into wounds. And we now know that hard to heal wounds, otherwise known as chronic, often will have biofilms. In fact, pretty much every single time. And the only way to treat biofilms we know now is through good debridement. Now, please, we're not saying to you all to go and grab a scalpel out like I do most days and debride that wound, but thinking about the other types of debridement, autolytic debridement, mechanical debridement, biological, so yes, maggot therapy. My company trains a whole 3-day course, sorry, on actually debriding wounds. So it's so important. But I want to talk briefly about the wound etiology. The AMA over this year has actually just published a fantastic document which went to Parliament to talk about the cost of treating wounds. And what they did really lovely is they looked at the hospital separations by types of wounds. And as you can see down the bottom, you can see that it's affecting arterial and venous ulcers, and it's certainly affected a lot of people with diabetic ulcers in that hospital system. But take a look, besides the venous and arterial insufficiency that come into the hospital, take a look at that very clear skyrocket up in that trajectory of how many diabetic wounds there are. And we know that diabetes is rising in the community, particularly poorer communities, rural and remote communities as well, Aboriginal communities. And so therefore, a lot of them will have issues with diabetic wounds. And that's why it's so crucial to refer early. So on that note, I would like to delve a little bit deeper into venous and arterial ulcers, and in particular, how do you assess them? How do you diagnose them? And what's our options and what should we be doing? Before we can do any of that, we need to start thinking strategically. Why do we need to focus on these leg ulcers? Well, it's because they have variable healing rates. They don't heal like most other wounds within 4 to 6 weeks. How many of you, think about it, know people that have been living with wounds as ulcers for many, many years? Jot it into the chat if you've got any long-term ulcers that you know of. I have 2 patients at the moment, one who's had their venous ulcer for 19 years and another patient who's had it for 21 years. So we're talking significant years. Assessment's not always holistic, and we'd like to change that if we can. There's bandaging challenges. We know that particularly for venous ulceration, that compression bandaging is the gold standard, but sometimes we may lack resources, we may lack the knowledge of how to apply them, but sometimes it just comes down to the patient not wanting to actually wear that bandage, and particularly in the hotter weather. Wounds can often be colonised and inflamed. Often there is a referral that's far too late. On average, my team will see referrals for ulcers usually after 1 to 2 years. We'd like to see referrals coming in if they haven't healed within 3 months, because 3 months is when you should really start to see the healing rate. Pain is often difficult to manage. And of course, there's confusion around diagnosis. So the question is, are there challenges of leg ulcer management? I think that it would be fair to say we agree there is. There is long-term chronic ulcers, there's complicated ulcers, different treatments, so it just creates a bit of confusion. So my question to you all is, how do you feel when a patient is referred to you with a leg ulcer? Feel free to drop it in the chat. If you have a patient come to you or you're working with somebody who has an ulcer, how do you feel? Do you feel confident? Do you feel, I like that somebody's written excited, that excites me. Do you feel that you could manage it? Do you have the resources? Do you have the knowledge? Or do you feel you might need to get some more support? Great comments, everyone. Thank you. But now I'll ask you a different question. How do you think your patient feels? Do you feel that they are comfortable to go out to the shop, to, be scared that maybe it might leak through that dressing, that they maybe stop going to bowls or stop going to work? I have a lot of patients who are sitting in the age range of 30 to 45 living with venous ulcers, and they are so embarrassed by it, they don't go out anymore. They don't see their friends. They don't go to the shops. They don't go to work. So absolutely right. Depressed, isolated, feeling of pain, spot on. So let me ask you, I'm going to put some pictures up on the screen, and I'd like you to, and please, it's a safe space, everyone, drop into the chat. Are we looking at a venous or arterial ulcer? Who wants to be bold and pop it in? Good, I can see a couple of things. Good, good, good. What about the next one? Picture number 2.
Hayley, I'm
Yes.
just going to jump in because I hate everyone. We have got like 226 people on the chat. Let's just go back one and get everybody off the fence, because we learn best if we have a goal. It doesn't matter. We will not go back and look at your name and say, oh, yeah, what you said. So please, everyone, get into the chat and let's do, that question, because exactly, some can't see the pictures. So we're actually now finding out that some of them are not watching the screen. So Andrew and Caitlin, we might just do a little, introduction, because sometimes there can be some technical where people can show gallery view so they can see both screen and comment. So we'll just take a little moment there. Good. I can see comments starting to come through now. And Andrew and Caitlin will come back to you, just suggesting some things on the pictures. There might be people who can only see one screen at a time. Okay.
Great.
So, because we actually really want to make sure that you can see the presentation, because for the next hour, there'll be lots of amazing pictures in this one. So
we're getting some responses.
We are definitely getting responses. So for those that can't see the picture, we will absolutely come back to you, because there's a few different settings you need to have set up there. Good. Okay, I'll go back on mute, Hayley. But all those who can see the pictures and the chat, awesome. Thanks for jumping off the fence and having a go.
I love that you're all answering. Good work. Okay, and then number 3, what do we think? Venous or arterial insufficiency? Great. I'm seeing a lot of things coming through. Those, again, like Anne Loney said, the team are working behind the scenes to support you with how to get your pictures up. Thank you to those that are responding. So the interesting answer is that all 3 are in fact venous ulcers. But the reason I show you this is because it's so easy to think that some of them, just by a quick look, could be in fact an arterial ulcer, because venous ulcers can be so variable. And the dilemma is very clear. They look very different, particularly when they have so much slough, as you can see on the left side. Venous ulcers and arterial ulcers are also very difficult when they're around that malleolus area, around the ankle. They're the hardest to treat. It's thicker skin down there. They often get a callus, so it's a really difficult area to manage. Well done for everybody who had a go. Good work. And those that can't see, I believe the team are working behind the scenes with you. So what do you do with infections? And that's quite often what we see with venous ulcers, is they get a lot of infections. And what happens when trauma becomes a leg ulcer? The amount of times that I've seen skin tears, in particular, basic skin tears, that after several months, they actually turn into venous ulcers. And that's quite often because they get some trauma on the outside of the leg. And then what happens is they've got venous insufficiency, so it can break down, in fact, to a venous ulcer. So how do you work it out? How do you decide what's venous, what's arterial? First, you start with the definition. And a leg ulcer is really a full thickness skin loss of the lower leg. The leg ulcer occurs in association with other disease processes. So whether it be arterial, vascular, or neuropathic diseases, and a leg ulcer may be acute or chronic. So it's important to know that they can be quite variable. Another interesting fact is that a lot of the times, and this was a point prevalence survey that was done and published, around 80% of the ulcers that you look at will in fact be venous insufficiency, 80%. The other 10% will either be arterial, or you can in fact get mixed, both venous and arterial insufficiency. So it makes it even harder to work out. So that's when we need to get back to basics. and have a look at what is the circulatory system. We know that arteries carry oxygenated blood to the legs and veins and carry deoxygenated blood away from the legs, right? The blood then returns. I've got all these pop-ups jumping over my screen here. And basically pumps it out again by the arteries. So if that's our system, then you've got to think what's happening to that lower leg. And so I'm wanting to show you a very short video here, but I'm going to point a few things out before I play it. So what you can see here are the normal veins, and inside those veins you've got valves. But when you get venous insufficiency, you actually get damaged valves. So take a look at this video on the screen. Oh, it doesn't want to play.
As always, it worked before, so we might just give it a second.
Yes.
Might just be because we've got many people on here.
But basically what will happen is the blood to be taken up against gravity back to the heart, the valves need to prevent the backflow. So essentially they need to close and stop that backflow. And failure to do that will actually compromise, and you'll get this pooling effect in the bottom, and that's otherwise known as venous insufficiency. And that's why it can be a complication. And it's a shame that that video is not working, but I'm happy to share that later.
I'm thinking, yes, you click, I hoped it would start. Okay, we'll share it in.
Yeah, I don't think it's going to start. That's okay. We can move on. You get the gist. Okay, so how do you progress to an ulcer? Firstly, you have those incompetent valves, those valves that are not shutting. Then what happens is you get that venous stasis, so the pooling. Then you get this exacerbated high pressure in that area, which then causes venous dilation. Tissues begin to flood. You get this intoxication and local ischemia, and then you get the breaks in the skin and the venous insufficiency. So when we talk about compression, and we're often saying, do I use compression on venous or arterial? If you go back to what venous insufficiency is, which is these damaged valves, you want to help those valves close. And the only way to do that, in fact, is to help push it back up. And that is why compression therapy is the gold standard to healing those venous ulcers quicker. There are some risk factors. It is, in fact, sometimes hereditary. Age can certainly be a contributor. I hate to say it, ladies, but females are more prone to getting venous insufficiency. And the statistics to that tells us, of course, there's issues with pregnancy, but also it's known in the literature that we're on our feet a lot more. Apparently, the literature, you can't blame me. Obviously, those that are obese or poor nutrition, prolonged standing. So a lot of flight attendants, they will often get issues in later life with venous insufficiency if the person's immobile or if they have varicose veins or diabetes. These are all contributing risk factors. And now let's take a look at, so that's the venous insufficiency. Those valves are not functioning. Absolutely, Sue, I agree. Us nurses, we're always on our feet. We will definitely get venous insufficiency if we don't protect our skin. But I'll also mention arterial insufficiency. And what happens here is we get this calcification, this build-up here, which basically stops the blood flow. And of course, that can happen by a number of ways. That can also be hereditary, often poor diet, high cholesterol. A number of those things will actually cause those blockages. So now put 2 and 2 together. Would you use compression on arterial insufficiency when you've already got blockages? Definitely not. And that is why it's important to understand, are you looking at venous or arterial insufficiency? So now I want to take you through the journey of, well, how do I know? What do I look at? I always start with this. Anyone who's come to my training, there's so many mnemonics out there. You can use whatever works for you and whatever you're using at your service. They all do a good job. I just personally like Heidi because I've used it for many, many years, 22 in fact. So Heidi stands for history, taking the person's history, getting to know them. What medications are they on? How do they get the wound? Are they smokers? Do they stand up for a long time? examining the wound itself, taking a look at that wound. What can I see? What can I smell? What's the surrounding limb like? What's the person's overall skin look like? Investigations. Get the Doppler. You must get a Doppler, ABPI or toe pressures in order to indicate what's happening. Diagnosis. You can then decide, what am I actually looking at? And you can then implement a plan because you've gone through a robust process. So this is just a structured approach to actual assessment, but it is one simple way to help guide you in thinking about what else do I need to look at and what have I missed. So when it comes to venous and arterial ulcers, if we start with venous insufficiency, we now know that the valves aren't shutting properly. We're getting that pooling, we're getting that venous hypertension, and that's what's causing the leg to break down and ulcerate. They often occur within the gaiter region, which means below the knee and above the ankle. So within that region, they're often jagged edges and they often have copious amounts of exudate. Very clear signs, but I'm going to say that's very textbook. They're not that easy all the time. When it comes to arterial insufficiency or arterial ulcers, they often will occur from the ankle down to the foot. They're often quite circular, as you can see in this one here, and they have what we call this punched out look. So if you stuck something in the leg and it looked like something was punched out, that is a clear indication that it could be arterial insufficiency. So what I would like to do now is have you all in that chat again, have a look at this wound. What are the characteristics that you see? Do you believe it to be arterial or venous insufficiency? Drop it in the chat. Give me your thoughts. There's no problems if you get it wrong. That's why we're here. Great. We've got a few people saying arterial. Anyone else? Yeah, it looks punched out. Okay, good reasoning. Keep them coming. Okay, looks like a high number of you are in fact saying arterial, so I will not hold you to it any further. You are absolutely spot on. This is in fact arterial. Now, I do understand why some of you are saying mixed because you've got that secondary, but this is a very clear circular, punched out looking wound. It's not jagged edges. So yes, it does have the characteristics of arterial ulceration. It doesn't mean that we stop there. That's when we do further investigations as we go through that Heidi assessment. What about this wound? What do we think? Arterial, venous, mixed, diabetic? What are you thinking? Got some comments coming in. Great. And I know there's so many of you online, so it is hard to catch everybody. But for those that have actually said venous insufficiency for this one would be spot on. And that is because if you take a look at this wound, you have the jagged edges. It is quite superficial, but take a look at the maceration, which you can often see by those white edges. That is usually a good indicator that there's lots of exudate and it's macerating the wound. It's also within that gaiter region, so above the ankle and below the knee. Now, again, we do a clinical assessment and we decide based on the characteristics of that wound, what am I thinking? Once you've done all that, that's when you need to do further investigations. Now, I do really like this chart, and I've got references at the end for you, but what it nicely does is it tells you the difference between venous ulcers, arterial ulcers, and neuropathic ulcers, sorry, I just lost my screen, and neuropathic ulcers. And it gives a nice comparison. Should they be painful? Should they not? What site do they usually sit in? The depth, the ulcer edges, the surrounding edges. So again, it's a guide. Nothing's ever this textbook, but it's a guide to support you through working through the challenges. Now, as I said, as you've gone through that Heidi process, you've assessed the person holistically, you've assessed the wound, you're now starting to think, oh, I think it's this type of wound. Well, your next step needs to be how you manage it. And by doing something like a Doppler assessment is crucial. Now, I'm fully aware that not everybody can do a Doppler assessment. Podiatrists have it as core in their training. Some pathologists will do it. Certainly my team and I will come out and do Doppler assessments. And there's, of course, your GPs and a number of other people and some practice nurses will often do a Doppler ABPI or toe pressures. So find someone in your local area that you can call out to support you with that. Because at the end of the day, we know that we all work towards one goal, and that is the patient comfort and the patient who has a wound that goes away quickly. And to do that, we need to think about assessing the wound well, assessing extrinsic factors and intrinsic factors, and having a look at that lower limb and what else could be done. And one of those things that's really crucial, guys, is doing a vascular assessment, a nursing vascular assessment. So how many of you actually will take a pedal pulse, a medial malleolus pulse, a popliteal pulse, a pulse in the groin? In other words, tracking up that limb to ascertain how, do I have any issues with the pulse? Because that's a very clear sign. Is the limb cool or too hot? You know, does it have an infection? Is it cool to touch because there's some fluid insufficiency? There's so many things to look at. Is there edema? Is there venous dermatitis? So lots of things to consider, but going through that Heidi assessment will certainly support you on the way to working out what your next stage of the job is. I always say, please don't forget about the different types of pain. This is really crucial because there are different types. Neuropathic pain in particular, there's lots of shooting pain, burning pain, tingling, stabbing, nociceptive pain, for example, dull, aching. There are different types, but I would always say to have a look at, is it neuropathic or nociceptive pain? But understanding the different types of pain is important because it will lead you sometimes to a different diagnosis. And there's also, of course, patients that can get hyperalgesia, which is that excruciating pain in the wound bed. So if you go to cleanse that wound and they're jumping through the roof, that may be an issue for them. Or is it allodynia, where the pain is in the surrounding skin? So you might not even be touching the wound bed, and you can't understand why that patient is jumping when you just touch the surrounding skin. Pain can also be from a non-painful event, such as the wound exposed to the air. So let's say you've got it undressed and they're sitting there saying, oh, it's just hurting, but when the dressing's in place, it doesn't hurt. And there's usual forms of, and the usual forms of analgesia, in fact, for these types of wounds don't often help. And that is why sometimes we do have to merge more to topical analgesics like lidocaine gel, or there's a number of others on the market that can support that. But what we want to do is examine the wound well. What does it look like? What am I seeing? What colours are there? Is there odour? What's the surrounding skin? These are all clues to telling you, because you need to ask yourself, is it macerated? And often maceration, as you can see in this picture, is shown with that white surrounding skin. Are you in fact seeing some granulation? Okay, so you can see that nice, pink, healthy looking skin. Is it quite sluffy? And can I tell you, if we don't do good wound hygiene and remove this, and yes, we all need to remove this through good, even autolytic debridement, or even getting out those microfiber cloths like Debris Soft, for example, and giving it a good mechanical debridement. I would come in with this with a sharp curette, for example. That will support that wound healing a lot quicker. Are you looking at necrotic skin? What do you do if you are? So there's so many things to think about, but one of the crucial things I'm going to keep going back to is getting that Doppler ABPI and toe pressures, because what it does is it tells us what compression level we can actually put in place. Now, if you ask your GP for a Doppler, they will likely get the medical model Doppler duplex, which is different to a Doppler ABPI and toe pressures. For the purposes of getting compression and working out what class of compression the person should go into, we actually do need that ABPI or toe pressures. Making sure you're doing that lower limb vascular assessment. If you need to, particularly if you have mixed ulcers or if you're just not sure on your diagnosis, yes, talk to the doctor. See about getting a Doppler duplex. We do apply compression for anyone for an ABPI above 0.9. And the crucial thing that you'll always hear us wound specialists say is please refer early, because we can often treat and get on track a lot sooner. And once a ulcer is actually healed over, and often we talk about skin closure as opposed to healing, that's when they're really in remission. And if we don't get compression garments on these people, often for the rest of their life, they have an 85% possibility of that ulcer returning. So it's really high statistics. And I just wanted to point out the Ulcer and Wound Management Therapeutic Guidelines. This was published in 2019. It shows clearly in this that Dopplers are highly recommended, that pedal pulses should be taken every time you're doing that dressing change, that you should be measuring the ABPI. And in fact, some of the newer literature in the last few years is leaning more towards toe pressure indexes, so Doppler TPIs. And making sure we're getting compression therapy on for those that can have it. And it's interesting that they also note in this area here that you need to be trained in how to apply compression. So if you haven't applied compression bandaging for a long time, seek out some support to train you. You can call our services, we do that, but there's lots of providers in the market that can help you with that as well. If the person's going into garments, the other tip I would give you, if they're now closed over and healed and you're now going to use compression garments, and let me be clear, that is not Tubi Fast and that is not Tubi Grip. Compression garments that are at different millimeters of mercury, then you need to replace them every 6 months is a good average. So having 2 sets and replacing them every 6 months so that they don't lose too much of that elasticity. And let's not be confused with other types of wound etiologies. For example, the one you're seeing on the screen right now is a squamous cell carcinoma. The next one is what we call a pyoderma gangrenosum. This is an immune system dysfunction. Often looks rather similar to a venous ulcer, jagged edges, a lot of exudate. But the key of these are they can be quite painful and they can have this what we call a purple hue surrounding that wound, a real key for pyoderma gangrenosums. Is it vasculitis, which is the inflammation of the blood vessels that can cause changes to the walls of those blood vessels? Or is it other sinister things like marjolin ulcers? Now, these are an aggressive ulcerating SCC as well, common in chronic wounds, and they often present in areas that were previously traumatized, so those that have scarred areas. So if you're seeing something like this over an area that has scar tissue, it could be a Marjolin's ulcer. They're very aggressive, and I would suggest if you're not familiar with them, get a specialist in to have a look. So what I always hear every time I do wound training is, just tell me, Hayley, what dressing do I put on that wound? And I never start with wound dressings. And the purpose is because if we start there, we get it wrong. We have to understand the person. We have to understand the history. We have to examine that wound and say, what are the characteristics? And we have to do further investigations. Once we've done that, then we can start pulling it together and say to ourselves, okay, there's lots of fluid here. This is the type of dressing I need to go to. Or it's really dry. I need to add moisture to it. This is the type of dressing, for example. So this is just a guide, and I don't want anyone to take it as anything else but a guide. But I would always cleanse your lower leg wounds and ulcers with either a neutral solution such as warm tap water, and I say that particularly for those in poor resource areas of Australia like rural and remote that don't have access to a lot of things. And when we say warm tap water, please warm it up, because it's so important that we're not putting cold solutions on our wounds or super oxidized solutions. I tend to use quite a lot in my practice microdacin solution. You may have heard of Prontosan and others. I particularly like microdacin because it sprays on, it's easy to use. you do need to remove necrotic and devitalized tissue through debridement. Now, debridement by whatever is within your policies and procedures. So can you use a certain dressing? Then put that on. Can you use mechanical debridement? Whatever you can use. Gangrene and eschar do not debride, however, until you can tell if they've got good arterial sufficiency. Dressings should maintain a moist environment. We've known that for many years. And the aim is manage exudate and the surrounding skin. And how you do that, I will often, anyone who has a referral by me or my team, our go-to is to always put a barrier cream around that wound. It prevents the wound from breaking down further, and it also stops maceration. So good emollients, good barrier creams, and of course, get a vascular consult. Things like endovenous interventions and surgery may be the required work that needs to happen for that person. And compression bandaging systems, as I said earlier, they will reduce the amount of time you have that wound. So if you can confirm it's venous insufficiency, if you've done all the work around it, got your Doppler ABPI or toe pressures, and you can say that, yes, it's a venous ulcer, put them in compression bandaging because it will reduce the amount of time they have that wound. Of course, it would be remiss of me if I didn't talk briefly about prevention. Obviously, we want to reduce the risk factors, so stopping smoking. And I know you're all sitting there going, rolling your eyes, going, how? I know it's difficult, but we need to talk about it. We want to maintain and control diabetes. So it's really important if you've got somebody with a venous ulcer and they are diabetic as well, check what their last HbA1c is, and that should be really done every 3 to 6 months, depending on how chronic they are with their diabetes. Good nutrition is crucial. I gave you the 3 elements to healing a wound at the start of this presentation. Good water, good food, good nutrition. So if we can focus on that, it will heal the wound. And we often talk about pushing fluids with patients with venous ulcers, and that's because they have lots of exudate. So if they have lots of exudate, they're actually losing lots of fluids. You need to top it up. So they need to have more fluids going in. You want to control elevated lipids, of course, and hypertension. Sometimes antiplatelet therapy is used. We want to control weight and get people to lose weight if we can. Exercise. Now, we spoke about the valves in venous insufficiency not closing properly and putting compression bandaging on to help close them. But you have the muscle pump in the calf that will do that for you the more they walk. So getting people up and walking more will absolutely help. Passive warming of the extremities, and as I've gone on and on about, compression garments long term. Overall management pathways should include referral, not only to a wound specialist, but a vascular assessment, good wound bed preparation, eradication of any infection, control pain, correct bandage selection, and what you want to see over 4 weeks period is good amount of percentage of decreasing of the size of the wound. So if you're going 2 to 4 weeks and not seeing any decrease in the size of that wound, something's stagnant and it's time to get it checked out. So that's the pathway. What we do need to talk about, however, particularly with venous and arterial ulcers, is the infection that can occur. And again, I'm going to bring your attention to the evidence-based practice. And there is a fantastic document out called by the International Wound Infection Institute called The Wound Infection in Clinical Practice. This is the latest one out. This is the Principles of Best Practice for Infection Control. Get your hands on this. It is free. You can download it. Go to Google. It's a great resource and it really talks through everything you need to know. So let's start with the principles. We know this. We know that infections often look like expanding redness around the wound. We get this yellow or greenish coloured pus, you know, like this lovely fluorescent, fluoro, gorgeous looking green. That ain't good. That's often Pseudomonas. You get red streaking spreading outside the wound bed. And how we talk about that is often that it's erythema. And we get a little bit concerned when the erythema starts to spread more than 4 centimetres outside of that wound bed. We can often get increased swelling, tenderness or pain, and sometimes we may get a fever. So these are the signs of infection that we need to keep an eye out for. So the question I often get asked is, should we do a swab or should we not? Back 22 years ago, we swabbed everything that walked into our practice. Everything was swabbed. What we now know now is we have an issue with AMS, antimicrobial stewardship. In other words, we've spent so many years over-prescribing antibiotics that people are now becoming so resistant to antibiotics, it's actually stopping them from getting better when they really get sick. So we have to be mindful. So when would you actually take a swab is the question here. When you're concerned, when you've done your clinical assessment and you go, you know what, I've looked at all these signs, not just the fact that there's a little bit of exudate there. Don't worry about that. The body is used to keeping the wound moist. It will create some exudate. That's the normal part of the pathophysiology there. But if there are other signs, redness, copious amounts of exudate, odor, pain, all those things, then yes, maybe you need to actually take a swab. So some key ideas of when to do that. When there's clinical evidence of the infection. If there is in fact a delayed wound healing process and you've tried everything to work out why, going through your Heidi system, and so that will indicate that you may need to actually do a swab. Or of course, if there's deterioration and you are not sure of the cause. Can I tell you a lot of the times with wounds, what causes deterioration besides the person's natural response, often what I see in practice, it's because people are not being consistent with the dressing type. Swapping it out, the dressing type every 3 days doesn't actually help that wound to start kicking along and healing. I'll show you this fantastic diagram that is actually in that document that I showed you, and it talks through the different levels, whether it's just contaminated, colonized, if it is a local wound infection, as opposed to a systemic infection. And why I'm pointing this out, because if it's a local wound infection with all of those signs and symptoms that you can see on the screen, often you can treat them with topical products. And what I'm referring to there is your dressings. So whether it's some form of antimicrobial dressing, silver dressing, whatever it is, to actually start to heal that, to remove that infection. When we start to come down to that systemic infection with these other signs, as you can see on the screen, yes, we may need oral antibiotics, or it may be so severe that they may need IV antibiotics and treatment. So getting that balance is crucial. Now, if you do have to take a swab, what we always talk about in all of the literature now is we have found that there's multiple ways to take a swab, but what is standing out as the gold standard is what we call the Levine technique. And Angel et al. In 2011 conducted a randomized control trial reviewing all the different types, and the Levine technique stood out as the most suitable for picking up what you needed to know in terms of organisms. And how you do that is, in fact, you actually do cleanse and debride the wound with warm normal saline. You then moisten the tip with the normal saline. You take the sample from the cleanest area. So in fact, looking at this wound on the screen, you're not going to take it from that mucky, exudate, pussy area. You take it from the clean area. And you do that by rotating the swab over the area and putting a bit of pressure by pushing down. And then of course you put it in the tube, you wash your hands after you've taken your gloves off, and you make sure that you clearly label information on that swab. For those that have never been into a lab where they actually take the swabs and analyze them, it is so important to put even down to detail, what is it, left or right leg that you're looking at? What are you thinking it is? You think it's a venous ulcer that's infected? Write it on there. The pathologist will love seeing that level of detail. So I've given you guys the foundations. And what I'm hoping to do now is bring it all together with some realistic life people who have lived through some of these wounds, and take you on a journey through how I assess wounds, what I think about, and the journey of a couple of case studies. So I'll provide one case study, and then I'm actually going to hand over to you to tell me what your thoughts are on the last case study. So I'm going to start here with Mrs. A. I'm very inventive with my names. And Mrs. A. So when we talk about Heidi, this is what I'm looking at. So in terms of history, you need to be aware that she's an 84-year-old. She does have non-insulin dependent diabetes. She has limited mobility. Her pain is significant. It's 7 out of 10. She lives in her own home and she gets nursing services in, and she's rather malnourished. So after sitting down with her and taking that level of detail, we could then examine the wound. She had her wounds for over 5 years. They were in the gaiter region. Her pulses, however, were okay. Her foot assessment, and I do a monofilament test, were all okay. She had moderate amounts of yellow exudate. She didn't have nil, she had no edema at this stage, but the wounds were very malodorous and rather macerated. So I had to do further investigations. I did a Doppler at the bedside, a Doppler toe pressure, toe pressure index. And I also asked the GP what was her latest HbA1c. And as you can see, for a diabetic at 14.9% and BGL's often over 12, it was quite a higher level. And I also did an albumin level to see what her nutrition was like, which showed me it was quite poor. The swab came back with MRSA. So the overall diagnosis for this wound is a right lateral lower leg chronic venous ulcer. The implementation plan was to decrease any microorganisms, so we switched straight away to microdacin solution. We did apply the barrier cream to the surrounding wound. We did originally start with, and you'll see on the next page a bit of a close-up and all of that very thick exudate. So I needed to focus on how do I take that off and de-slough it, because debridement, sharp debridement was not a request of the patient. She did not want to have that, even though we convinced her she would not feel it. She wasn't comfortable. So we had to come up with another way. So we actually used the product HydroClean, and you've got Hartman here today who may talk a bit more on that. And then we switched it a bit later on to silver dressings, and of course compression bandaging. So as you can see here, that's the original photo you just seen. That's a close-up. So it's very characteristic of a venous ulcer. You've got the jagged edges, you've got lots of exudate, very thick tenacious slough within that gaiter region, and of course we did the Dopplers to know that it was that. And what I can show you is this is it after 6 weeks. 6 weeks. This lady had this wound for 5 years, and all it took was 6 weeks. We did 3 weeks of the HydroClean just to take away that yellow slough, and then we switched it over to the silver dressing. And what I'm very happy to say is that 6 weeks after that, we actually, so 12 weeks total, the wound was completely healed. But if you have a very keen eye, one of the things you might notice is that there's a bit of edema there now. And so our job may be done with the fact that we've actually removed the exudate and we've healed that skin closure, but the edema remains or has actually gotten worse. And that is because after 6 weeks, the patient did not want to wear compression bandaging anymore, despite our encouragement, despite I always start low. Here's another tip for you. I always start low with compression bandaging. So start with a light compression first and build their tolerance up. But yes, she just wasn't tolerating it. She was getting quite a bit of pain, but we healed that wound. So it was a great outcome. So what I'd like to do now is throw to you all and get your chat open, because I'm going to present to you a wound, and I'd just like you to drop in the chat, what would you cleanse it with? What would your primary dressing be? What would your secondary dressing be? And how would you fix that in place? So I will read through the patient's story. Again, Mrs. A, because I'm so inventive, 72-year-old. She has rheumatoid arthritis, and that is important. Why? Because she's on a drug called methotrexate. And for a lot of you, you would know that methotrexate is a cytotoxic medication, and cytotoxics will often delay a wound from healing. Again, this patient had limited mobility due to pain. In fact, her pain when I first seen her was 10 out of 10. She lives in a residential aged care home, and her diet was okay. She had these wounds for 15 years and she had just arrived at the aged care home. I am going to point out for those that are saying, oh, who hasn't got gloves on there? That was actually the daughter, and she had been doing dressings at home for a long, long time. We couldn't convince her otherwise to put gloves on. But she had the wounds for 15 years. As you can see, copious amounts of exudate. That product there is not even holding that exudate in. You can see how extensive that size of that ulcer ulcer is. The swab, however, was NAD. Pain management was serious, so we needed to do further investigations. We did a pain chart so that we could map, does she need further analgesics? And of course, I did a Doppler TPI. So the difference between a ankle brachial pressure index is you will take, to do a Doppler, you will actually put the cuff around this part of the leg. Now, if we've got a wound there, it makes it very difficult to do that, which is why we're now moving more towards toe pressure index, where you put the cuff around the big toe. And of course, this is a venous ulcer. So I'm now going to throw to you all to tell me in the chat, what is your primary dressing? What is your secondary dressing? What are you going to fix it in place with? And how will you cleanse it? So take a look. I've given you the Heidi assessment process. I'd like to hear now from you all. And look, we're going to get some differences in products, and that's okay because you have to work with what you have at work. So thinking of that, throw some ideas at me. What would you put on this wound? Have we got any questions? Oh, here we go. Yeah, Debris Soft Scrub. Good work, Tina. Absolutely would recommend that. Saline or Prontosan soak. Yep, or then microdacin. I'd probably suggest one or the other is suitable. Great, great. Bactigras. Sure, but however, Bactigras might actually cause too much maceration. You need something really heavy to soak up that fluid, a product to soak up the fluid. Warm water, sure, great, excellent. If you can drink the water, you can certainly use it. Cleanse it with normal saline, absolutely. Debride it, Zip-Sock, yes. Zip-Sock, however, may float off this initially just because of the amount of exudate. So I'm seeing some wonderful, wonderful suggestions here. Silver dressing, absolutely. That, in fact, is what we did. So, and a lot of you are on track to exactly what we did at Zetravet Plus, absolutely. So in this instance, we actually cleansed it with microdacin. We applied a barrier cream to the surrounding wound. We applied a silver dressing that also soaked up the fluid. And we did use Zetravet Plus, funny enough, and we used compression. And that is because we knew that this patient had venous insufficiency. So great job, everybody. Somebody's mentioned iodosorb paste. You could, however, I would steer more for the powder if you were going to use that, because in this instance, you'll probably find it would float off. Debride it, yes, absolutely. Great. Great, great, great suggestions. So we have gone through the journey tonight, guys, of working through what are the issues in Australia and globally. How do you assess appropriately and manage wounds? What do we need to think about? So here's my take-home messages. Wounds heal due to physiological processes. They can fail for multiple reasons, such as non-concordance. The person's age and infection can all be contributors. The focus should shift to making sure we protect the skin as the first line of defense. Avoid infections by managing the bacterial load, prep the wound for success, and of course, think about antimicrobial dressings. And on that note, they are my references for tonight, and I thank you all very much. Thank you, Anne-Loni. Back to you.
Thank you so much. And I'm just smiling because that was fantastic. I hope everyone, doesn't matter you're muted, just at home, give a big clap. Let's just give a big clap. Yeah, you can put thanks and claps into that. And we'll do the Q&A a bit later, but I just wanted to make sure. So Hayley is here to answer all our questions. But thank you, Hayley. Yeah, not only your knowledge, which is just amazing, but your whole energy and the way you go about it is just really awesome. Yeah, thank you for all of those thumbs up and smileys and comments in there. That's great. We will just let Hayley have a sip of water and breathe before we hit the Q&A. So what we'll do now is we'll hand over to Danielle Wheelahan from Hartman to actually talk about this app on how we can help health professionals choose the right wound care. So Danielle, take it away.
Thank you so much. So yes, I'm Danielle from Hartman, and tonight I'm going to be talking to you about the very exciting Simply Wound app that was launched early this year. It really does take the complexity out of wound care. So I'm going to share with you how to register a little bit later, but once you do register, you can search via indications. There's about 8 in total. So for example, skin tears or pilonidal sinuses. There's an extensive range of Hartman products that you can view, application guides, news and events to keep you updated, some really great content and resources. Yep, next page. And then again, next page. The really unique thing that the app does provide is the ability to click on the fields, which then can provide some product suggestions. So for example, on the screen here, you can see exudate level. You can click on if it's 1 drop or 4 drops, the wound color, whether there's bioburden present, whether you want something that's self-adhesive or not, waterproof, and also the ability to cut. So it's fantastic in that sense. Next slide. The thing that I really want to focus on here is the link hub. So once you register, you actually have access to this link hub, which is, as I mentioned, free. The Link for Wound Healing e-learning is an online education program addressing multiple topics of interest for the daily practice of healthcare professionals. When you're actually in that site, you can do some modules and it can give you a certificate thereafter. There's also some webinars that we house there as well, and some really great scientific content. Next page. So how do you download the app? So the app is available on the App Store or Android app on Google Play. There's actually a QR code on the screen there that you can scan now. So I really encourage you to download that and have a bit of a play. There's also some new updates that will be released in January. So very exciting to see those being launched. So watch the space for those. Hope you enjoy, and thank you so much for Hayley for a very impressive presentation this evening. Thank you.
Great. Thanks, Danielle, for running through that. And, you know, the app and any tool that can help us here is really valuable. So just one page before we jump to the Q&A. You might know or already have seen we have our summer specials out. There are some lovely bonus gifts there. For example, that massage gun, the mini, if you buy for $3,000 in total, and some other things. But at the bottom of the page, and this will be in the thank you email you get tomorrow as well, because you spent your night with us, we will give you 10% off your next Team Medical order. No matter what you order, it's all our products, 10% off, and the voucher code is in there. But now let's get to questions. Have you had some water, Hayley? Are you ready? Are you good to go?
Ready to go. And if can I jump in if that's okay, because I picked up on a couple of questions that were coming through, and look, rightly so. There are some parts of Australia, whether it's GP practices, rural, remote, even just some of our regional areas, that will not have the ability to purchase specific products. And that's why I'd say to everybody on the line, it takes an army to get through to our politicians. So that is why at Wounds Australia, and I am going to give them a little plug right now, if we can work together, we can come up with schemes to support subsidised products, and it's something we're lobbying for. So I'll start there. There was another question about what about 2 or 3 layer tubing grip? Yeah, sure, it has its place. Obviously, the gold standard would be a specific compression, whether it's a 20 millimeters of mercury or you want to aim for up to 40 millimeters of mercury, but that may not be an option, and the patient may not want to wear compression no matter what you say. So you have to, as clinicians, we're always thinking outside the box and inventing things. So if you've got to go with 2 or 3 layers of tubing grip and that's all you've got at the time, go ahead and do it. It's going to give at least a little bit. So to give you an idea, it's been estimated that tubing grip will give around 8 to 12 millimeters of mercury, and to heal a to heal a venous wound, you need 40. Now, please don't go and put 8 layers of tubing grip on. That's not what I'm saying here, but 2 to 3 layers may be a little bit of support for that person.
That's great. Thank you. And marketing Caitlin here has been helping keeping an eye on all the questions. So I will shoot a few more questions to you that has come through. I know you did answer this, but I'll just bring it up again. How can you do an ABI on someone with a lower leg ulcer? Because you did talk to that, but let's just acknowledge that question did come up. So maybe just to repeat there.
Yeah, so that's why we are moving more towards the toe pressure index. So rather than putting the cuff over that wound, and how many times have you all sent somebody off to have that Doppler and they've come back and you get the report that says, oh, couldn't really do a clear assessment because they had bandaging on. So that is why we're moving more to toe pressures, because the cuff goes around the toe. So if you think about a blood pressure machine and the cuff, it's a little baby one that goes around the big toe.
Great explanation. Let's move to cleaning. Someone would like your thoughts on Medisponge and Betadine. And another question linked, do you ever cleanse with Medisponge?
Medisponge I'm not too familiar with. Doesn't mean you can't use it. I would always say think about what's the principles of that product and what are you trying to achieve. The question about Betadine always comes up, and I may annoy some people here, but what Betadine has been known for, and we've used it for many, many centuries. But what it does is it dries the wound out, and it dries it out sometimes so that you can't actually work on healing that wound. Now, Betadine has its place in some areas. For example, if I had a necrotic heel, for example, like a pressure injury, an unstageable pressure injury that was necrotic, and it was so far gone, it was to the bone, I would simply paint it with Betadine, because all you want to do is provide that antimicrobial approach. Or perhaps let's say somebody has a fungating wound, okay, that does not want surgery. So therefore your goal of care, which is why Heidi is so important, is to just manage the symptoms of pain, odor and exudate. So I'll just spray that with Betadine every day. But to be honest, I often do not use Betadine on good, healthy tissue. Same with chlorhexidine.
Thank you. And I can see more questions coming in. So let's just quickly go back and make sure we cover the ones that were there. So about the barrier cream, how close should you go to the wound with a barrier cream?
Great question. Just to the edges. You actually don't want that barrier cream to touch the wound bed, okay? Because that needs that primary dressing that you're putting on. And I'll just go a step back again and touch a little bit more on cleansing. What tends to happen is we will cleanse the wound bed. And now what the literature is telling us, you actually need to cleanse quite often the whole limb. And the reason is because you have those organisms just running around. And so if you just do that wound bed, as soon as you pull that product off, they're running into that wound. So keep them at bay and give the leg a good wash, allow it to dry, and then put your barrier cream around it. How do we convince GPs not to use Betadine? Right, I would say best practice, evidence-based practice. Feel free to call out to my team. I think we talk to a multitude of people. You know, I often ask GPs why, and I work a lot with surgeons and I do a lot of training for surgeons, and I say, why Betadine? And they're like, well, we rely on the nurses because we don't really know too much about wounds. So it takes a collaborative approach, but having the evidence backing the detail is so crucial. So yeah, not an easy question to answer.
Awesome. I'll shoot some more questions because they're coming fast now. So just one more on barrier protection. Quite a lot of people mentioned Vaseline, which is beautiful. And sorry, everyone, for my Danish pronunciations here, but I hope you get it. Are Bepanthen and Vaseline suitable for barrier protection?
Vaseline, not so much. Vaseline tends to make the area too moist and it can break down the skin, but the other barrier creams you mentioned, fine, suitable. Any barrier cream that will support that skin from breaking down. Whatever you have in your kit for a barrier cream, providing it's got no fragrances in it and it is a medical grade barrier cream, suitable.
Beautiful. Let's jump to something else. How often should we change dressings?
Oh, another great question. Everyone wants the golden question.
And we've only got 19 minutes to talk about that one.
You'll need at least 20 years for this one because there actually is no no answer. But what my team and I teach is the 3 to 5 day rule. Okay, and this is purely based on experience and not literature. Okay, because there's actually nothing in the literature of how long a dressing should stay on. So there's two things I'd say here. One, have a look at the manufacturer's guidelines. How long does it say it can stay on? And we always use a 3 to 5 day rule, which means we'll put a dressing on and the first change will be within 3 days. And we will come along 3 days later, take the dressing off. And if it's holding, we might bump it up to 5 days. And if after 5 days we come back and it's still holding and there's no fluid seeking out and the manufacturer says you can have it on for 7 days, we'll leave it on for 7. But our 3 to 5 day rule is kind of what we teach.
Fantastic. Thank you. What about cleaning in the shower?
Yeah, again, no problems, but I'm going to give you a little tip. And I see this a lot in aged care because it's the carers, and there's no problems with that. We need to utilize our carers more. They're great sources. In fact, I call them skin experts because they see the skin the most. But give them a couple of tips. When they are in the shower, the first thing that will happen is you might be showering and you're washing their hair, and what happens with all that soap? It goes straight down into that wound. So one of the things we suggest, just like you do now, and you put a bag around it, bag it up, wash the person first, then take the bag off, take the dressing down, and give that wound a thorough wash. So to answer your question, no problems with washing it in the shower, but you don't want contaminants going into that wound. So think about your process and flip it around.
Beautiful. Here's another one. Please talk about silver flamazine cream. Do we need both the cream and the silver dressing?
No, you don't. You're doubling up would be my response there. We used to use flamazine quite a bit on burns. We don't do that so much now. One of the, I work with some very high profile burn specialists, and the go-to now is to jump straight to a silver dressing.
Right, we stay on the silver. Do you apply the silver ActiCoat with Hyperfix and then wet 3 times a day?
With Hyperfix and then wait 3 times a day. Okay, so again, it's I don't tend to use Hyperfix. I would put a secondary dressing on first, so I wouldn't put silver and then Hyperfix. I would put silver and maybe a pad dressing such as Zetravet, Mesorb, whatever you've got, and then your fixation device, because you don't want it straight on. Would you change it after 3 days? I can't answer that because you would have to have a look at what's the characteristics of that wound. Is there lots of exudate? Is it holding when I come to it in 3 days' time? And then you would need to clinically assess, do I take it off in the next 4 days or do I come back again in 3?
Yeah, that's great. Thank you. We'll keep them coming here. There's just a little tip. Chronic wound soaking with Lux soap. Is it a good practice?
Not anymore.
Okay.
And it's simply because we know now a lot more about biofilms. We know a lot more about microorganisms, and how you need to think about it is if we're putting any wound and into a bucket, we're actually just putting it into a bath with a lot of bugs. So yeah. No, we don't do that anymore.
Thanks for that one. Any tips for managing pain before, during debridement? Do you use any topical analgesia to help?
Yes, so I will, depending on the type of debridement that we are doing. So, if you're just using a microfiber cloth, for example, that shouldn't hurt. And if it is, there's something else happening, so look into that. But if I was to start sharp debridement, I would either use lidocaine 2% or EMLA cream. EMLA cream, there's been a great PhD doctor who's completed and published some work around EMLA for the purpose of debridement, and both are over the shelf at your local pharmacy. Obviously, if you're in a health setting, you would have your GP chart it, but yeah, that's what I use.
Great. We'll take a few different ones here. Which barrier cream do you recommend? Is zinc a good option?
No, we've gone a little bit away from zinc. It does a number of things to changing the bio oils on the skin. And if you think about it, back in the day, any of the old nurses in the room with me, because I'm one of them, you'd used to have to get a spatula to scrape it off the next time round because it was so thick and it just stuck on there. And that's because it doesn't actually adhere to the skin too well. So what are the ones out there? Well, Hartmann, I had some products up on the screen of their Molicare range is a great product. I seen somebody drop into the chat earlier about QV barrier cream. That's another one. Cavalon, there's several on the market. Just do your research and understand the best ones that are available.
Great. A different one. Would you suggest 10 to 15 minutes vitamin D exposure daily if the patient's situation allows?
Such a controversial question, because 15 years ago, there was a huge study done on vitamin D. To the point where they said it's not enough just to sit outside. You should also take vitamin D oral tablets, particularly if you're over a certain age. That research has swapped and changed over the last probably 10 years to say it does work, it doesn't work. But I think I would say that based on the literature, it's never a bad idea to get somebody outside, because it does a couple of things. Not only gives them that vitamin D in the sun, but gives them the oxygen that they need, gives them a change of environment to change their endorphins, to get them thinking clearer and better, which all, believe it or not, aims to heal that wound. We know that if we control pain, because pain is a real factor, if you've got somebody with a lot of pain, it will delay that wound from healing. So if you can control that, even by distraction of getting outside for 10 minutes, then that is a good way to go.
Beautiful. We'll have to do some quick, sharp questions and answers just to get a few more in. The first one I think is easy. Can we get information on the wound debridement course? We've had a few of those. We will share Hayley's details when we send it out tomorrow. Absolutely reach out because there's so much information out there. When the MRSA wound healed, can we say the patient is not positive for MRSA anymore?
Good question. So what does the literature tells us, and I'll always go back to the evidence-based practice as I keep drilling into everybody today. If somebody has MRSA in the wound and it's been 6 weeks and you're still dressing it, that MRSA remains as a potential infected wound until it closes over and heals. That's the recommended information. The question I usually get as a follow-up is, do I need to do a swab after it's healed? The research I've read suggests that no, you don't. Because if it's healed, it's considered to be containing the potential infection. And again, MRSA can sit there dormant, doesn't need to be active and cause systemic infections.
Thank you. Tips on management of a wound/sinus post-old osteomyelitis.
Great question, and hard wounds to treat. So firstly, is the osteomyelitis managed and on track? Have they had either IV antibiotics, oral antibiotics, and they're out of that acute phase? Managing the sinus can be very tricky. So it's dependent on how deep is it. Can you actually put a dressing inside that wound to soak it up? Or quite often with a sinus, they're so pinpoint, you can't get anything in it. And at those times, if it's going to be leaking continuously and the person's not fit to go back and have surgery to have it what we call a washout and closing it up, then sometimes we will use something like an ostomy bag over it to capture that fluid with good amounts of barrier cream.
Beautiful. We will close for more questions. It is amazing. We could spend all evening together, but it matters for us that we actually wrap up on time as well. So Andrew will get our little survey link ready to put in the chat as well. We'll just take the ones that got in before we said stop. So can we use Epiderm as a barrier cream on the wound edge?
Sure. Again, if you've got that in your kit and that's all you've got access to, fine.
What compression bandaging do you recommend? I only have crepe bandages and Tubicrip at my GP clinic.
Yeah. Okay, so this is where getting your evidence-based information out to your GP to let them know, if we want to stop this patient coming back to us every 3 days, then we need to get them in compression. What would I recommend? It depends on the person's age, tolerance, and will they wear it. And if they'll wear it, and they're young enough, I would go with 40 millimeters of mercury. So it doesn't matter which one you're using. I often find compliance is better on 2-layer. There is differences between 2-layer, 3-layer, and 4-layer, but if we're talking about compliance, 2-layer is better. And if they're older, they're quite often, that's the non-concordance cohort of patients that I see. So I always start them on light compression. So if you're not sure what I'm talking about with 20 millimeters of mercury versus 40, have a look at any compression that's out there, whether it's Coban, Ergo K2. Danielle, have you guys got a compression bandaging? There's Cedo Press, there's Jolps range, there's so many out there, but have a look for light and normal, light and standard types of compression.
Beautiful, thank you. And I'll take the last one we got in. There's more questions coming, but what we'll do is while you all fill out the little survey that we'll put a link in now, in a minute, then you can just have a quick look, Hayley, if we have 1 minute at the end. But the last official question, can I debride with forceps? If not, what should I use?
Yeah, okay, so I would assume you're probably talking about the plastic forceps. And back in the day, we used to, and I could be wrong here, but back in the day, I also did it where you would crack the forceps in half because there's a serrated edge on one side, and you would give that wound a good scrub. On the occasion, I still do that. To be honest, it's just dependent on what's the patient's tolerance if there's too much pain there. And it's usually only because I have nothing else in the kit. In other words, I've gone somewhere. I have a lot of homes in rural and remote areas of Australia, and the resources out there are not great. There's no point me taking my kit out there because when I leave, what are they going to be using? They're going to be using what's on their shelf. So I do show them that technique, but we often will couple that with either oral pain relief, which has minimal effect, but usually a topical, as I said earlier, product for analgesia.
Beautiful. Thank you. While you have a sip of water, if you could go to the next slide, because there's a QR code. So right now, all of you, please, we have a survey. It will take you 1 minute. So either with your phones, if you're on the computer, just scan that QR code, and otherwise in the chat, Andrew put in a link. If you wouldn't mind clicking that link, and if you'll just start right now answering a few questions, it's really fast and quick. It would be really helpful for us and all of those who will join in the future webinars. And when you have started doing it, you can continue after we've wrapped up here. But I would love for you to just take a moment, take your time to just click that link so we can get that moving. And while everybody is doing that, I really want to say thank you again, Hayley. That was absolutely fantastic. What a great presentation. Value to the right, you know, the last minute in advice, and very pragmatic as well. You know, we do what we can do in the environments we're in, but as well we have a voice. You know, together we can, you know, speak louder, both to our practices and to the politicians. So thanks for that that one as well. So to all of you, because I can see some people are starting to drop off, and I totally get it. Thank you so much for being with us here. Tomorrow you will get an email with thank you, links to the Watch on Demand, so you can go back and look through all of this. Take your time, pause. Yeah, so that will be in the email tomorrow. There will be a PDF with your certificate. So for that 1.5 hours worth of CPD points. So and your voucher code. So with the 10% off from Team Medical Supplies. So do remember to open that email. And you can continue filling out the survey. We really appreciate it. But I think that's it, Hayley. I think that was absolutely fantastic. Any closing words from you?
Oh, look, just thank you. I know it's, you know, the workforce is really bad at the moment with COVID that's brought to us. And for anyone that can get on to spending more time into the night as well to come to these, I'm just so humbled and grateful that you could come out, and you have a real need to, a want to learn more about wound care, which you know, touches my heart. So thank you, everyone.
Yeah, well said. Thank you, everyone. We will give you 5 minutes back of your evening, but thanks for finishing that survey. We really appreciate it. And for any ideas you have for more webinars we can do in 2023, thanks for the claps. Have we got any hearts for Hayley? Can you know use your little reaction? I'm going to find a little heart to send you there. Oh. Yeah, that was absolutely. Yeah, that was amazing. Thank you so much.
Thanks, everyone.